A big goal is to prevent a seizure. Preeclampsia, pre is before, and eclampsia is a seizure that can happen, and we would like to prevent this from happening. The main medication that we use to prevent seizure activity with preeclampsia is magnesium sulfate. Magnesium sulfate is a central nervous system depressant, and it's given typically IV. It could also be given IM, but it's harder than to control that. So giving it IV gives us the opportunity to turn it off if we need to, if we see signs of toxicity. Because that this medication is going to take the excitability of her neurologic system and bring it down a touch, that's what we want. But if we depress things too much, we can cause severe symptoms like respiratory depression, absent deep tendon reflexes, lethargy, somnolence, things like that. So we're doing frequent monitoring and assessing her neurologic status at least hourly. And we have on hand an antidote in case she does show signs of toxicity, and our antidote is calcium gluconate. We're also watching her urine output because magnesium sulfate is metabolized through the kidneys. And remember that with severe preeclampsia, we could see oliguria. And we really need that urine output to be greater than 30 mLs per hour for her body to metabolize through this medication correctly. So we're watching the urine output as well. And then the other thing that we're going to need to consider is that with magnesium sulfate, we're going to be giving this to our patient from the time that we start it until 24 hours after her baby is delivered. And so for those 24 hours postpartum, the magnesium sulfate can have some effect on the contractility of the uterus in the postpartum period because it can decrease the contractility. And in postpartum, we need the uterus to contract to control bleeding. So we're also monitoring for that as well. We're going to be managing her high blood pressure. So the magnesium sulfate can have some effect on the blood pressure, but it is not the most reliable way to manage her blood pressure. So if she continues to have blood pressures that are greater than 160 over 110, we're going to be giving other medications. And the medications we typically use here are labetalol, nifedipine, and hydralazine. Labetalol is given IV. If we don't have IV access yet, if she was just admitted and we have just diagnosed her preeclampsia and we haven't gotten an IV yet, nifedipine can be given PO to start to bring that blood pressure down. Labetalol tends to be the medication that's used most frequently once we have IV access, but hydralazine is also a good other alternative.